Hello everyone and welcome to this video of our internal medicine board review questions in nephrology. This is part 2, glomerular diseases. I am Dr. Mohammed Tinawi. I'm a nephrologist in Northwest Indiana. This video is not only helpful if you're taking a board type exam, but it's also helpful if you would like to understand glomerular diseases. So let's get started. The key to understanding glomerular diseases is to know the anatomy of the glomerulus. Now first, let's look at a normal human glomerulus. Really take a mental picture of this because once you know what's normal, it'll be easy to know what's abnormal. Now, you can see here my pointer. This is a glomerulus. This whole thing is a glomerulus. You can see the space here. This is the Bowman space, and the cells that line Bowman space are the renal epithelial cells. And actually the cells on the outside of the loops, of the capillary loops, are also renal epithelial cells. These cells here, they're called podocytes. So then we have two kinds of renal epithelial cells. The cells here lining Bowman's capsule, and the cells here that are called podocytes. Note that this space is empty. There's nothing. Then we have these capillary loops. They're thin and they're nice, and you cannot really see anything in them. It's like you've drawn them with a pencil. Now the cells that line these capillary loops are the endothelial cells. So here, these are endothelial cells. Now, in between these capillary loops, you have the mesangium, and the mesangium has mesangial cells. So then we have epithelial cells, including the podocytes. We have endothelial cells on the blood side, and in between we have the mesangium, which has mesangial cells. Here you can see the proximal tubule. Here you can see the macula densa, which is in between the afferent and efferent arteriole. Now this is another look. Here you see the glomerulus, same thing, and the rest of the slide has renal tubules and blood vessels, of course. Note that the renal tubules are back to back. There's not much space in between them. So you see some space in blue, but not a whole lot. Okay, so that's important to know. Now this is a schematic. We have here, this is again a glomerulus. This is Bowman's space. Like we said, it's lined with renal epithelial cells. And these two are also renal epithelial cells. They're called podocytes. They have these little legs. This is why we call them podocytes. So this is a podocyte, this is the nucleus, and these are the legs or the podocytes of these cells. This is the Bowman space. This is the proximal convoluted tubule. And on the opposite side, we have the vascular pole, and we have here the efferent arteriole going in, the afferent arteriole going out. In between, we have the macula densa, a part of the distal tubule, and this whole thing, efferent, afferent, macula densa, is called the juxtaglomerular apparatus, and this apparatus produces renin. Now, if we take a portion here and we magnify it, we can look at this very important schematic. Here we have three parts. In the middle, we have the GBM, the glomerular basement membrane. On the inside here, we have the endothelial cell. This is the endothelial cell. So this whole thing is the endothelial cell, and we call it fenestrated endothelium because of these spaces. Fenestrated meaning like window-like. Okay, So this is a red blood cell. On the inside, we have the endothelial cell. Then we have the glomerular basement membrane. And then we have the podocytes, okay? These are the extensions of the podocytes. Look how distinct they are. They're not effaced. They're not fused together. And in between here, you see this blue line, blue line, blue line. It's called the slit diaphragm. So in a little bit, when we're going to talk about immune complex deposits, we're going to talk to them in relation to this diagram. Is it going to be intramembranous in the membrane? Is it going to be subendothelial below the endothelium? Is it going to be subepithelium below the epithelial cells, or a combination of both? Is it going to be mesangial? Unless you understand the anatomy, you cannot understand glomerular diseases. So these first 10 slides I'm showing are critical, and feel free to watch them again and again until you're very comfortable. This is another schematic. I want to emphasize the same point. Okay, this is the capillary loops. Capillary loops. On the inside, like we said, we have what? The endothelial cell, and then in black, glomerular basement membrane. On the outside, we have the podocytes. This is a podocytes, and these are part of the podocytes, okay, the little legs, if you will, podocytes. These are the renal epithelial cells, lining Bowman's capsule. This here in white is Bowman's space, okay? Podocytes, podocytes, podocytes. What's here in between is the mesangium, and the cells here are mesangial cells. This is the vascular pool where you have the efferent and afferent arteriole, and in between you have the macula densa, and all that will constitute the juxtaglomerular apparatus. And this is the tubular pole, or where the proximal convoluted tubule takes off. One more time, okay? If this is not clear, let's go over it one more time. This is an electron microscopy picture. Here is the basement membrane. This is the endothelial cell. So this is the capillary lumen, fenestrated endothelial cell, and these are the foot processes of the epithelial cell, or the podocyte. And we really determine where the immune complexes are deposited depending on their location relative to endothelium, glomerular basement membrane, or the epithelial cell foot processes, or the podocytes. Now, this is an example of probably the most active immune process, SLE, systemic lupus erythematosus. So if we have someone with lupus nephritis, really we can have immune complex deposits everywhere. Let's put the knowledge we just acquired into action. Here in the green, in the middle, we have the mesangium. We have the mesangial cells. So if we have antibodies here, we call them mesangial antibodies. Examples of that is lupus. Lupus is always going to be an example, or IgA nephropathy. Again, in the green, if we have antibodies, these are mesangial antibodies. Okay, now, here, this is a podocyte. And then you have the glomerular basement membrane here, and here you have the endothelium. So we always have to orient ourselves. This is a capillary loop, endothelial cell, fenestrated endothelium. This is endothelial cell, glomerular basement membrane, podocyte. So what do we call these deposits here in blue? We call them subepithelial deposit, because they're below the epithelium. The epithelium is this podocyte, and they're below the epithelium, which make them above the glomerular basement membrane, or epimembranous. So they're below the podocyte. I hope this is clear. Now, these deposits here are below the endothelium, so we call them subendothelial deposit. Sub, again, is below. Now, if we had deposits here inside the membrane, we call them intramembranous deposits. So the deposits can be either in the mesangium, they can be subepithelial, below the podocytes and above the glomerular basement membrane, or they can be subendothelial, meaning below the endothelial cell, which make them also below the glomerular basement membrane. These definitions are critical. When we talk about a glomerular disease, we use a lot of terms. What does diffuse mean? Diffuse means a lesion involving 50% or more of glomeruli in the sample we collected. So if we have a biopsy, and on the biopsy specimen we have 30 glomeruli, and we have a lesion involving over 50%, over 15 of them, we call it diffuse. Focal, it means that there is a lesion, but it involves less than 50%. So 50% or more, diffuse, less than 50%, focal. When we're looking at a single glomerulus, if the lesion involves the more than half of the glomerular tuft, okay, the capillary loops inside the glomerulus, the glomerular tuft, then we call it global. If it involves less than half, meaning a segment of the glomerular tuft, we call it segmental. So when we say that the lesion is focal and global, focal means it involves less than 50% of the glomeruli, but the glomeruli that are involved more than 50% because they're global. If we say that it's focal segmental glomerulosclerosis, it means that the sclerosis or the scarring is focal, so less than 50% of the glomeruli, but it's also segmental. Glomeruli that are involved in less than half of their glomerular tuft. Very important concept. Patterns of injury. Okay, now this is the biggest secret about glomerular diseases. When you read a pathology report, when we throw terms like focal segmental glomerulosclerosis, crescentic glomerulonephritis, membranoproliferative glomerulonephritis, this is a pathological diagnosis. This describes a pattern of injury. It's not a clinical diagnosis. So when you have focal segmental glomerulosclerosis, it can be idiopathic, primary, it can be secondary. It can be secondary to hypertension, it can be secondary to any burned out chronic glomerulonephritis. So we have to recognize the pattern of injury, and then we put all the information together to reach a clinical diagnosis. So if we have a mesangial pattern, it means that we have antibodies attacking the mesangium, the space in between the capillary loops. And the prime example is IgA nephropathy. IgA, the antibodies are deposited in the mesangium. And you have microscopic hematuria, sometimes gross hematuria, and subnephrotic proteinuria. Usually it's less than 3.5 grams per 24 hours, so that makes it subnephrotics. There are many exceptions, of course. Endothelial pattern, like you see in lupus, like you see in vasculitis. Here you have acute reduction in glomerular filtration rate. You have hematuria, can be gross or microscopic, and proteinuria is usually not nephrotic, okay? It's mild to moderate. If you have an epithelial pattern of injury, this is something that is going to affect the podocytes. So here you have significant proteinuria. This is where you have your most diseases with nephrotic range proteinuria, okay, like minimal change disease, membranous nephropathy, focal segmental glomerulosclerosis, also amyloidosis, diabetic nephropathy, even like membranous lupus nephritis, etc. Here, again, you have manifestations like the nephrotic syndrome. You can have some microhematuria, but not a lot, okay? You're not going to have red blood cell counts. You're not going to have a very active urinary sediment except for the proteinuria. Now, like I said, what I just described is pathological involvement, but clinically, we have 5 syndromes. This is how we're going to see the patient. We're either going to see acute glomerulonephritis, a sudden drop in GFR associated with edema, high blood pressure. A prime example is post-streptococcal glomerulonephritis. Can be post-strep, but actually can be after any infection. This is why we call it now post-infectious glomerulonephritis. Okay, so this is an example of acute glomerulonephritis. Rapidly progressive glomerulonephritis, we're going to talk about that in some details, like you have with vasculitis, polyangiitis with granulomatosis, microscopic polyangiitis, etc. Chronic glomerulonephritis, any glomerulonephritis can become chronic, like membranous, like FSGS, even something vasculitic now went into remission and you still have chronic manifestations. Nephrotic syndrome, I mentioned examples, minimal change disease, FSGS, membranous, and symptomless hematuria and proteinuria. Sometimes you have just a little bit of proteinuria or hematuria or both with not much symptoms. You see that a lot in mild cases of IgA nephropathy, sometimes early stages of Alport's, or actually any disease early on. Whenever we look at someone with glomerular disease, age really matters because we narrow our differential diagnosis depending on the age of the patient. You can see here minimal change disease really is a disease of children and youth. You can still see it in people in their 70s and 80s, but usually you see it in children. Okay, after age 15 it starts to taper off. FSGS also is a disease of the young, okay, maybe a little bit older than minimal change disease. You can still see it in every age, but also it goes down. Membranous, on the other hand, is a disease of older people over 40 and 50. You can still see it in the young, but not very often. Now, membranoproliferative, or they call it in Europe mesangioproliferative or mesangiocapillary glomerulonephritis, also a disease of the young, okay, 30, 40, okay. This is what you can see with lupus, cryoglobulinemia, anything associated with hepatitis C, etc. Proliferative diseases, lupus and such, also younger people, 30, 40, but you can still see it in every age. Diabetes, more in older people. Amyloidosis, definitely people over 50, okay, more than 60, 70. Lupus, young women, okay, 30s and 40s. After this important introduction, we're ready to start with our cases. I'd like to let you know that I have an article published on glomerular diseases. It's a nice summary and an update, and I'll provide the link below. Let's start with our first question. Here we have a 62-year-old man presents to his primary care physician office for a routine visit. His average blood pressure readings at home taken at different times over the past month is 128/71, so good blood pressure. He has had type 2 diabetes mellitus for 2 years and his blood sugar is well controlled with just metformin. What is the best way to screen for proteinuria in this patient? So we have someone with 2-year history of type 2 diabetes mellitus and hypertension. A, 24-hour urine collection for creatinine and protein now and then repeat annually. B, urinalysis now and then repeat every 3 months. C, random or spot urine protein. D, random or spot urine albumin creatinine ratio now and then repeated at least annually. Now here you can pause the video, think about which answer you would like to choose because the answer is going to be on the very next slide. So pause if you like. The answer is D, random or spot urine albumin creatinine ratio now and then repeated at least annually. So doing a 24-hour urine collection is not wrong, it's just laborious and there are many errors or mistakes. The spot urine, especially if it's done in the morning, is pretty good, okay? The correlation with 24-hour urine is good, and we generally follow trends. So whether someone has 1,100 milligrams or 1,200 milligrams, it doesn't matter that much. We follow the general trend. So to do 24-hour urine collection now and repeat annually is not easy for the patient. So it's not the best answer. Your analysis doesn't tell you about the amount of protein, so it's not good. To check just the protein without a ratio is not good because we use the ratio. This will eliminate problems with whether the urine is concentrated or diluted. So we usually with diabetes, we check albumin creatinine ratio. You can check protein creatinine ratio, but most of the studies were done with albumin creatinine ratio. And we repeat it annually. If we have a problem, we're treating someone with an ACE or an ARB, then we are going to check this spot test more often. Sometimes if you have heavy proteinuria, someone with lupus, etc., sometimes we do a 24-hour urine collection just one time as a reference point, and then we follow with spot urine, albumin or protein and creatinine. So no one does annual 24-hour urine collections anymore. So this is why D is the best answer. So we continue to warm up here. Question number 2. 24-year-old woman with a known history of SLE presents for a routine visit. So we know that the patient has systemic lupus erythematosus. This systemic lupus erythematosus is well controlled with hydroxychloroquine. Her urinalysis shows 2+ protein, 10 red blood cells per high power field, 8 WBCs per high power field, and 1 red blood cell cellular cast. Random urine albumin creatinine ratio is 577 milligram of albumin per gram creatinine. So this is like having 577 milligram of albumin per 24 hours. C3 and C4 are both depressed. Anti-double-stranded DNA antibodies are positive. What is the next step in the management of this patient? A, 24-hour urine collection for creatinine and protein. B, initiate treatment with prednisone and cyclophosphamide. C, a diagnostic renal biopsy. Or D, initiate treatment with rituximab. The answer is going to be on the next slide, so you can pause here if you like. The answer is a diagnostic renal biopsy. Whenever you see someone with lupus, the answer is going to be a biopsy. We want to know what class of lupus nephritis we have, and then we tailor the treatment accordingly. So doing a 24-hour urine collection, I just said we really don't need that, so that doesn't add much. We know that the patient has proteinuria, and she has a very active urinary sediment. You have red blood cells, white blood cells, 1 cellular cast. Starting treatment with prednisone and cyclophosphamide is way too early. We don't have a diagnosis yet. Rituximab really has no advantage for lupus nephritis on top of established medicines like prednisone, cyclophosphamide, azathioprine, calcineurin inhibitors, mycophenolate, etc. So it's the wrong answer, and plus, again, you don't have a diagnosis. So lupus nephritis, like in this patient, you need a biopsy. That's it. End of the story. Okay, question number 3. 54-year-old man presents with hyperlipidemia, creatinine 1.2 milligram per deciliter, urine protein creatinine ratio of 2,500 milligram of protein per gram creatinine, albumin 3.1 gram per deciliter. A renal biopsy was done. It reveals membranous nephropathy. So you have the diagnosis here. Anti-PLA2R, this is M-type phospholipase A2 receptor antibodies are positive. Okay, so this is in the serum. The patient has no evidence of malignancy. What is the next best step in the management of this patient with membranous nephropathy? A, initiate treatment with prednisone. B, initiate treatment with rituximab. C, conservative management with an ACE inhibitor and a statin for 6 to 12 months. D, initiate treatment with prednisone and cyclosporin. Now the answer is going to be on the next slide, so you can pause if you like. The answer actually is C, conservative management with an ACE inhibitor and a statin for 6 to 12 months. Why is that? Well, this patient has membranous nephropathy. About a third of patients go into spontaneous remission. So before we give treatment with potential for a lot of side effects, we can wait. Notice here that the proteinuria is subnephrotic. It's below 3.5 gram. Creatinine is good, so there is no hurry to do that. The NTPLA2R, this is probably the most important discovery in membranous nephropathy over the past 50 years. So these antigens, the PLA2R, are on the podocytes, and then you have antibodies directed to that. So now most people with membranous nephropathy, about 70%, have these antibodies. So finally, we know what's going on with membranous nephropathy. Usually, patients with malignancy, with secondary membranous, they don't have these antibodies. And you can actually look for these on the kidney biopsy. You can do immunofluorescence staining for those, or you can do a serum test, and you can follow patients with membranous nephropathy based on the level of these antibodies. You can predict relapse, you can see response to treatment. Treatment with prednisone is not good now or later, because prednisone alone is not treatment for membranous nephropathy. So this is always wrong. Rituximab with the prednisone is a good option if the patient has say over 8 grams of protein right away, creatinine is starting to go up. After 6 months or more, there's no spontaneous remission. Prednisone and cyclosporin is another good option, as good as rituximab, and also, but you have to wait first. Now, one clue to why rituximab and prednisone and cyclosporin are wrong, because both are used for treatment of membranous. So if B and D are both correct in certain situations, it means that we cannot have two right answers. It means that both are wrong. Or this is a bad question, but this is not a bad question. So the initial treatment of membranous nephropathy, when you have subnephrotic proteinuria, patient is stable, is observation. You treat with an ACE or an ARB plus a statin, and you wait, hoping for spontaneous remission. Question number 4. Here we have a 57-year-old African-American man presenting with acute onset bilateral lower extremities edema. The patient has hyperlipidemia, creatinine 1.4 milligram per deciliter, urine protein creatinine ratio 5,500 milligram per gram, and albumin of 3 gram per deciliter. Urinalysis does not show hematuria or casts. Serological evaluation is unremarkable. This means C3, C4, hepatitis B and C serologies, ANA, HIV, serum and urine protein immunofixation. What is the most appropriate next step in his management? A. Treat empirically with prednisone for 3 months, then proceed with a renal biopsy if urine protein creatinine ratio remains over 300 milligram per gram. Usually we define complete remission when you have below 300 milligram per gram. So if you don't have complete remission, then you do a kidney biopsy. B. Treat with an ACE inhibitor and an SGLT2 inhibitor like canagliflozin, empagliflozin, or dapagliflozin. Those are the SGLT2 inhibitors. And proceed with a renal biopsy if creatinine rises to above 1.6 milligram per deciliter. Option C, observation for 3 months, followed by repeat laboratory evaluation. Then you decide what you want to do. D, proceed with a diagnostic renal biopsy without delay. You can pause for a second and the answer will be on the next slide. The correct answer is D, proceed with a diagnostic renal biopsy without delay. Here we have a man presenting with elevated creatinine, nephrotic range proteinuria, hypoalbuminemia, hyperlipidemia, okay? And this patient has nephrotic syndrome. We don't know what the diagnosis is. It could be focal segmental glomerulosclerosis. It could be membranous, possibly even minimal change disease. We don't know what the diagnosis is. We have to do a kidney biopsy. So the point here, if you have nephrotic range proteinuria, and you don't know where it's coming from, like sometimes it's obvious it's from diabetes, it's diabetic nephropathy. You have someone, long history of diabetes, they have diabetic retinopathy, they have neuropathy, poor control of diabetes. It's pretty obvious. Here we don't have history of diabetes because I did not include that in the stem, meaning it does not exist. So you have to do a diagnostic renal biopsy. A reminder what the nephrotic syndrome is: 24-hour urine protein over 3.5 gram, or if you're doing a urine protein creatinine ratio or albumin creatinine ratio, it's above 3,500 milligram per gram. Hypercholesterolemia, edema, and hypoalbuminemia. You need to have low albumin. Okay, question number 5. The renal biopsy on the patient in question 4 reveals minimal change disease. What is the most appropriate next step in his management? Do we give him prednisone? Do we give prednisone and mycophenolate mofetil or Celcept? Do we observe him for 3 months and then prednisone if the patient is not in complete remission, meaning we still have more than 300 milligram of protein per gram creatinine? Or do we go to rituximab? Now the answer is going to be on the next slide. You can pause if you like. The answer is prednisone. So any patient, child or adult, if they have minimal change disease, we start treatment with prednisone. Okay. Now, when they don't respond to prednisone, if you have a frequently relapsing patient, if you have someone who's corticosteroid resistant, then you add other agents such as a calcineurin inhibitor like cyclosporin, like tacrolimus. Sometimes you can consider rituximab. But first line of treatment for minimal change disease is always going to be prednisone in children or adults. Minimal change disease follows an epithelial pattern of injury. The injury is to the podocytes. So here we have podocyte injury by antibodies and complement. Now, we don't have an exudate, meaning we don't have white blood cells, okay? The white blood cells do not infiltrate the glomeruli. It's non-proliferative. Again, when we look at the cells in between the capillary loops, okay, we find about 3 per loop, okay? When it's proliferative, we find more than that, and I'll show some other slides later. So the capillary wall lesion is non-exudative and non-proliferative. This pattern we see in minimal change disease, we see in focal segmental glomerulosclerosis, and we see in membranous glomerulopathy. Why? Because the injury is to the podocyte. It stays on the outside. So here you can see the arrow pointing to the podocytes. Now the foot processes are effaced. Remember our earlier slides when they were distinct, there were spaces between them. Here, it's just a continuous line. So this foot process effacement is very characteristic of minimal change disease. You can see it in other diseases, but in minimal change disease, this is the only thing you're going to see. So, if you have someone with minimal change disease, you look at the light microscopy, there's not much going on, pretty much normal glomeruli. This is why it's called minimal change disease. You do the immunofluorescence microscopy, you don't find anything either. The only way to make the diagnosis is by electron microscopy. And here you have foot process effacement. Very characteristic of minimal change disease. Now, because the antibodies are attacking the podocytes, they stay on the outside. This is the glomerular basement membrane. The injury doesn't spill over into the endothelium and into the vascular space. This is why it's non-proliferative, non-exudative, because the injury does not reach the blood vessels. Why? Because of this barrier, the glomerular basement membrane. This is another example. This picture is from my article I told you about. Same thing. This is the glomerular basement membrane. This is the endothelium, and this is the epithelium. These are the podocytes. You can see the effacement, okay? You don't see distinct processes. Okay, I put the arrow here to show the effacement. Let's talk for a second about minimal change disease. It's more common in children. It is sudden, okay? Usually minimal change disease and primary focal segmental glomerulosclerosis, abrupt onset of nephrotic syndrome. The patient comes in very swollen. Some patients even have ascites. The etiology may be deficiency of Tregs or regulatory T cells or suppressor T cells. The main treatment in patients who are steroid sensitive is corticosteroids. You're not going to know who's steroid sensitive and who's not unless you try. Other agents are used if the patient becomes steroid dependent or having frequent relapses. In the past, we used cyclosporin. We don't use it very often. It works really well, but it has many side effects. Hemorrhagic cystitis, can cause infertility, bladder cancer, etc. Now, if we find that corticosteroids are not enough, we're going to add a calcineurin inhibitor, meaning cyclosporin or tacrolimus, sometimes rituximab. Now, the problems with calcineurin inhibitors, once you stop them, you can have relapse. So you have to taper slowly. Treatment with rituximab is promising, and it's effective in both children and adults with frequently relapsing nephrotic syndrome. Question number 6. 27-year-old man presents with a 4-week history of bilateral lower extremities edema. The patient also has hyperlipidemia, a creatinine of 1.9 milligram per deciliter, and a protein creatinine ratio in the urine of 4,100 milligram per gram. Albumin is low, 2.9 gram per deciliter. Urinalysis does not show microhematuria or casts. Past medical history is significant for hypertension and IV drug abuse. A diagnostic renal biopsy reveals collapsing focal segmental glomerulosclerosis. What is the next step in management? A. Treat with prednisone. B. Initiate treatment with an ACE inhibitor, an SGLT2 inhibitor, like I said, canagliflozin, empagliflozin, or dapagliflozin. Proceed with corticosteroids if there's no improvement, especially in the proteinuria, in 3 months. C. Obtain ANA, anti-double-stranded DNA, antibodies C3 and C4, or D. Test for HIV. The answer is going to be on the next slide, so you can pause. The answer is test for HIV. Now, this patient has many features that can make us think of HIV nephropathy. The patient has nephrotic range proteinuria, so over 3,500 milligram per gram. The patient has hyperlipidemia, has elevated creatinine, has bilateral lower extremities edema. He has history of IV drug abuse, okay? Now, moreover, collapsing focal segmental glomerulosclerosis is characteristic of HIV nephropathy. So treatment with prednisone is not really helpful. You have to test for HIV and treat the HIV, and that will help the renal function. Now, treatment with an ACE or an SGLT2 does not really solve the problem. Probably it is pretty good, but still you have to treat the HIV. Like I said, corticosteroids are not mainstay treatment for HIV nephropathy. They've tried that in the past, but now we have really effective treatment for HIV. Obtaining ANA, anti-double-stranded DNA, C3 and C4 is good, and it should be done, but still you have to test for HIV. Now, on this slide, we see a patient with focal segmental glomerulosclerosis. Obviously, here we see one glomerulus, but note here that this segment of the glomerulus is sclerosed. It is scarred. This is the PAS staining, periodic acid Schiff. Now, the rest of the glomerulus looks pretty good, okay? So the main thing here is this segmental scar. This is why it is segmental glomerulosclerosis. When we say focal, it means that less than 50% of the glomeruli have lesions. Now, this is another example. Here we have 1, 2, 3 glomeruli, and again you see this segmental scarring here. Here you don't see much. You see an increased mesangial matrix in between the capillary loops. You see this adhesion to Bowman's capsule. This is also characteristic of focal segmental glomerulosclerosis. Now, this is another example. Here you see the capillary loops are really nice and thin here, and then you see this segmental scar, okay? So it's less than half of the glomerulus. If it were more, we would have called that global sclerosis. And this is the case in our patient, collapsing FSGS in HIV nephropathy. Here you cannot make the glomerulus anymore, okay? So here you have this infiltrates, and this is what's left of the glomerulus. You cannot make out the capillary loops, you cannot make out the anatomy, the mesangium, so it's like the glomerulus has collapsed on itself. Here you have adhesion to Bowman's capsule. You have also like proliferation on of the podocytes in the periphery. So this is collapsing FSGS. Let's go now to question number 7. 31-year-old man presents with recurrent gross hematuria post-upper respiratory tract infections. Laboratory evaluation reveals a creatinine of 0.9 mg per deciliter, urine protein creatinine ratio of 100 mg per gram, and albumin of 4.1 gram per deciliter. Urinalysis shows microhematuria and 1+ proteinuria. Past medical history is significant for celiac disease. The patient has no hearing loss and no visual loss. The patient does not have family history of renal disease. A diagnostic renal biopsy was done. What is the most likely diagnosis? A. Minimal change disease. B. Alport syndrome. C. IgA nephropathy. Or D. Membranous nephropathy. You can pause the slide here for a second, and the answer is C. IgA nephropathy. So here we have many clues that this is IgA nephropathy. Big clue, gross hematuria recurring after upper respiratory tract infection. But you can see that also with Alport syndrome, which is X-linked hereditary disease. You have in Alport syndrome usually hearing loss, visual problems, and you have problems with the glomerular basement membrane. Another condition that can give you something similar is thin glomerular basement membrane disease. Celiac disease is known to be associated with IgA nephropathy. So here you have microhematuria, recurrent gross hematuria, 1+ proteinuria, celiac disease, no hearing loss, no visual loss, then you have IgA nephropathy. Could it be minimal change disease? Well, minimal change disease is more nephrotic, sudden onset, lower extremity edema. Here you have only 100 mg of protein per gram creatinine. So it's really not characteristic. Alport, like I said, you don't have family history of renal disease, you don't have hearing loss. Membranous nephropathy, usually in older patients, also the presentation is more nephrotic. This is more nephritic. You have more microhematuria, gross hematuria, and a little bit of proteinuria. So this is nephritic, not nephrotic. Now, this is what you would see on the light microscopy in a patient with IgA nephropathy. You just see increase in the mesangium here, 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 in between, okay? So just looking at that, you cannot say that this is IgA nephropathy. You have just a mesangioproliferative lesion, okay? So you have a little bit here, these in blue, the white blood cells, you have somewhat increase in number. Same thing here with IgA nephropathy. It's a mesangioproliferative lesion. So here in pink, you have widening of the mesangium, 1, 2, 3, 4, 5, 6. You shouldn't have in any one loop more than 3, so you have more. So it's a mesangio because it's increase in the mesangium, proliferative because you have more than 3 white blood cells. But this is all you can say. The only way to make the diagnosis is by immunofluorescence microscopy. So I said with minimal change disease, the only way to make the diagnosis is via electron microscopy. With IgA nephropathy, the only way to make the diagnosis is by immunofluorescence microscopy. And here in the green, you see these IgA mesangial deposits. So diagnosis confirmed. What is the pathophysiology of IgA nephropathy? Here in the blood, we have IgA1. Okay, these IgAs are abnormally galactosylated, meaning the galactose on them is abnormal. Now, because of this abnormality, the body is going to elicit an immune response. You're going to have antibodies towards the body's own IgA. Now, when you have an antigen and an antibody, you're going to have immune complexes. So you have IgA1 IgA or IgA1 IgG immune complexes. These immune complexes are going to go to the kidney and bind to the mesangial cells. And once they bind, this is going to lead to complement activation, and this will lead to expansion of the mesangium. You're going to have proliferation and eventually scarring, glomerulosclerosis, and this what you see in some patients with IgA nephropathy when they progress to end-stage renal disease. About 20% or so can have end-stage renal disease in 10 years. Not everyone. Some people have a really mild condition. But it starts with abnormal IgA1 molecules. The galactose on these molecules is abnormal. That generate antibodies. Antibodies plus the IgA, you have immune complexes. They're going to deposit in the mesangium of the glomeruli. This will elicit complement activation. This will lead to damage in the form of mesangial proliferation and eventually in some patients scarring. Question number 8. What is the most appropriate management for the 30-year-old man in question number 7 with biopsy-proven IgA nephropathy? So no, we did a biopsy and we found IgA nephropathy. How are we going to treat this patient? As a reminder, creatinine was 0.9, so it was normal. The urine protein creatinine ratio was 100 milligram per gram, so not much. Albumin was normal. And like I said, the urinalysis showed microhematuria and 1+ proteinuria. So are we going to treat with corticosteroids? Are we going to treat with an ACE or an ARB? Are we going to treat with budesonide and mycophenolate, or are we going to treat with sparsentan and an angiotensin receptor blocker. So you can pause for a second or as long as you wish, and the answer is going to be on the next slide. The correct answer is ACE inhibitor or ARB. Why? Corticosteroids. Corticosteroids are beneficial if you have nephrotic range, but they have a lot of side effects. In the STOP IgA trial, patients with corticosteroids benefited, but they had a lot of side effects. So we cannot just recommend them in everyone. Probably we can not recommend them, okay? But in select cases, you can think about it. Budesonide and mycophenolate, you can use budesonide if you have significant proteinuria. I don't know why you would combine that with mycophenolate. That answer doesn't make any sense. Now, sparsentan is an endothelial endothelin blocker and an angiotensin II blocker, so it's both. So you can also use it if you have significant proteinuria, which we don't have here, and moreover, you cannot combine it with an ARB because it's like an ARB and an endothelin blocker, both. So if you combine it with an ARB, you're going to have more hypotension, acute kidney injury, and hyperkalemia. It's like using an ACE and an ARB together. It's not a good idea. So the correct answer in this patient with mild IgA nephropathy is going to be an ACE inhibitor or angiotensin receptor blocker. If the proteinuria increases, then budesonide or sparsentan is a good idea. If you're going to use sparsentan, you cannot use an ARB or an ACE. Just use the sparsentan. Question 9. 67-year-old man presents with a 4-week history of bilateral lower extremities edema, hyperlipidemia, a creatinine of 1.1 milligram per deciliter, and urine protein creatinine ratio of 8,100 milligram per gram. Albumin is 2.4 gram per deciliter. Urinalysis shows microhematuria and proteinuria. Past medical history is significant for hypertension, type 2 diabetes mellitus, and COPD due to 40-pack-year smoking history. Serological evaluation is unremarkable. A diagnostic renal biopsy reveals membranous nephropathy with negative immunofluorescence staining for phospholipase A2 receptor PLA2R. Serological testing for anti-PLA2R antibodies is also negative. Which of the following is the most appropriate management in this patient? Is it treatment with prednisone? Is it treatment with prednisone and tacrolimus? Is it treatment with rituximab? Or do we need to order appropriate cancer screening before treating this patient? The answer is going to be on the next slide, so you can pause. The answer is order appropriate cancer screening. This patient is a 67-year-old man. He has severe COPD. He has a 40-pack-year smoking history. So, as you know, membranous can be primary or secondary. 70% of patients with primary membranous have positive PLA2R antibodies in the serum, and you can see that on the kidney biopsy. This patient is negative. So that raises the possibility of secondary membranous. Then you add the smoking, and then you have to do appropriate cancer screening for this patient. So you need really to do a colonoscopy. You need to do CT scan to rule out lung cancer, like low radiation screening, CT scan, etc. So you have to rule out a malignancy before you give the patient inappropriately immunosuppressive treatment that could worsen the malignancy. Moreover, if you treat the malignancy, the membranous is going to go into remission. Now, here on this slide, you have 4 stages of membranous. So early on, you have some immune deposits, and like I said before, they're sub-epithelial. So these are the podocytes, the epithelial cells, and you have a little bit of deposits here in the dark blue, okay, below the epithelial cells. Now here, you have more deposits, and here in white is the glomerular basement membrane. Okay, now here the deposits are becoming bigger and bigger, and there is a little bit left of the glomerular basement membrane. And finally, in stage 4 membranous, the glomerular basement membrane is gone. You cannot even make out the deposits. They all become one, and the glomerular basement membrane is distorted, and you have heavy proteinuria. That barrier, the glomerular basement membrane, now is destructed, and proteinuria is just going to come out. Now, this is what membranous nephropathy would look like under the light microscopy. Look here at these capillary loops. They're thickened. If you look here very closely, you can make out some spikes, but these are not like the nice, thin capillary loops. It's not proliferative. You don't see a lot of white blood cells, but certainly it is thickened. The mesangium here is increased. Now, silver staining is very good. So here now you can clearly see these spikes. And spikes, these means like I showed you 2 slides before, you have these immune complexes, and the glomerular basement membrane is in between. So this is why you have spikes. So these spikes are because of the deposits, and the glomerular basement membrane is in between. You don't see them very well in every capillary loops, but certainly anyone with some experience can tell that this is membranous, okay, based on this. Now, obviously, you do immunofluorescence staining, and you see also that the deposits in the glomerular basement membrane. Now, here you see clearly this is the electron microscopy. Let's orient ourselves. This is the capillary lumen, red blood cell, endothelial cell. This is the glomerular basement membrane. This is the epithelial side, the podocytes, and all these deposits. All of these are subepithelial. Here, 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 etc. So you just orient yourself, okay? This is the endothelial side, red blood cells, glomerular basement membrane, podocytes, and subepithelial deposits. Now, this is for sure membranous nephropathy. As I said before, the most important development in membranous nephropathy is the discovery of the phospholipase A2 receptor antibodies, the PLA2 receptor antibodies. So here we have the podocyte, this is the cytoplasm, this is the membrane, this is the extracellular space, and this whole thing here, this is the phospholipase A2 receptor, and in membranous you have antibodies towards these receptors. So 70% of patients with primary membranous nephropathy have these antibodies, and since this came out over 10 years ago, around 2009, we've discovered over 10 different type of antibodies. But for your purposes, if you just remember the PLA2 receptor antibodies, that's enough, and you can do serologies, you can follow the course of the disease based on these antibodies. Moreover, if you have a case and you're suspecting membranous and it's pretty mild, probably it's be enough to prove the diagnosis to have these antibodies, and you may not need to do a biopsy. So it's that significant. We'll move now to question number 10. Here we have a 78-year-old woman presenting with gross hematuria and hemoptysis. Her past medical history is significant for type 2 diabetes mellitus, ITP, anemia, atrial fibrillation, and hypothyroidism. Her medications include diltiazem, glipizide, warfarin, levothyroxine, and digoxin. On exam, blood pressure 124/58, heart rate 68, but otherwise it was unremarkable. Urinalysis showed 2+ protein, 250 mg per deciliter of blood, 0 to 5 WBCs per high power field, 15 to 20 RBCs per high power field, 10 to 15 renal epithelial cells, occasional granular and white blood cell casts. Blood tests show BUN24, creatinine elevated 1.7 milligram per deciliter, hemoglobin 8.9 gram per deciliter, platelets 207,000. A 24-hour urine collection revealed 826 milligram of protein. Because the patient has hemoptysis, a CT scan of the chest with IV contrast was done and it was negative. Abdominal and pelvic CT with IV contrast only showed a simple cyst on each kidney, otherwise it was unremarkable. What is the most appropriate diagnostic step in this patient? Do we do HIV testing? Do we do serological testing for anti-PLA2R antibodies? Do we check Anca panel, or do we do a cystoscopy? Now the answer is going to be on the next slide, so you can pause here if you wish. The correct answer is obtaining Anca panel. Now, HIV testing is not going to tell us much. This patient has no risk factors for HIV. She is really nephritic, so you have less than 1 gram of proteinuria per 24 hours. You have microhematuria. You have red blood cell counts. So this is nephritic, not nephrotic. Serological testing for anti-PLA2R antibodies. This is when you're suspecting membranous. And again, membranous is nephrotic, not nephritic. Now, Anca is very appropriate. You have hemoptysis and you have hematuria. That's it. When you see that, you are going to suspect a pulmonary renal syndrome. You are going to suspect a vasculitis. You have to order Anca right away. Cystoscopy, I suppose, okay, you have microhematuria, someone older, you want to rule out bladder cancer. It's not a bad idea, but here you have an emergency situation and you have to make the diagnosis, and Anca is very appropriate. So indeed, in this patient, we checked p-Anca and it was very positive, 1 to 512 titer, and we have a positivity for anti-myeloperoxidase antibodies, over 100. On the other hand, c-Anca is negative, and anti-PR3 antibody, anti-proteinase 3, is less than 1. So we have a strongly positive p-Anca, anti-myeloperoxidase, and a negative c-Anca, anti-PR3. ANA is negative. Complements C3, C4, CH50 are normal. Anti-glomerular basement membrane antibody is negative. Cryoglobulins are negative. So the next step was a renal biopsy, of course. What is the most likely diagnosis? You can pause for a second, think about the diagnosis. Is it granulomatosis with polyangiitis, formerly known as Wegener's granulomatosis? Now we call it GPA, granulomatosis with polyangiitis. Is it microscopic polyangiitis, MPA? Is it anti-glomerular basement membrane disease, or Goodpasture's disease? Is it eosinophilic granulomatosis with polyangiitis, formerly known as Churg-Strauss disease? So think about which diagnosis you think this is, and the answer is going to be on the next slide. The answer is B, microscopic polyangiitis. Why is that? Now, on clinical grounds, it's not easy to distinguish granulomatosis with polyangiitis from microscopic polyangiitis. With granulomatosis with polyangiitis, sometimes if you're doing a kidney biopsy or a lung biopsy, you can see granulomas, okay? But most of the times you're not going to see that. The distinguishing factor is Anca. c-Anca is sensitive and specific for granulomatosis with polyangiitis, for GPA or Wegener's. While with microscopic polyangiitis, you're going to have a positive p-Anca, anti-myeloperoxidase. So c-Anca or anti-PR3 is going to be positive with granulomatosis with polyangiitis. Remember that. p-Anca or anti-myeloperoxidase is going to be positive for microscopic polyangiitis. Anti-GBM disease, and we call it Goodpasture when you have lung involvement, well, the antibody was negative, so it's really unlikely. So I told you that in the stem. Now, eosinophilic granulomatosis with polyangiitis or Churg-Strauss disease, This really doesn't cause severe renal involvement. And you have history of asthma, and you really don't have that. Now, this is what the biopsy looks like. Now, this whole thing obviously is the glomerulus, and these are the capillary loops. And look at here. This is called a crescent because it's like a crescent moon, and it's really squeezing, pressing the glomerulus. And you see all these cells here. So this is a cellular crescent. When it's all fibrous tissue, it's called fibrous crescent. Or you can have a combination. So this is really bad news, okay? So you have crescent squeezing the glomeruli. This glomerulus still looks viable. If you don't treat right away, it's going to be scarred over. So now we did the biopsy, and we know that the diagnosis is microscopic polyangiitis, okay? The pathological diagnosis was, and this is what the kidney biopsy is going to say, focal, meaning it involves less than 50% of the glomeruli, segmental, meaning it involves less than 50% of any single glomerulus, necrotizing, meaning you have dead tissue, crescentic because of the crescents, and sclerosing because of the fibrosis and scarring. Glomerulonephritis is pauciimmune. Pauciimmune meaning on the immunofluorescence microscopy, it's very close to negative. Okay, you don't see IgA or IgM or IgG, C1q, kappa, lambda, etc., and it's P Anca-associated. So this is the pathological diagnosis. The clinical diagnosis is microscopic polyangiitis, like we said. 13 out of 43 glomeruli were completely sclerosed. 6 out of 43 had segmental sclerosis, with some having cellular, some fibrocellular crescent, squeezing really the glomerulus. So if you don't treat right away, this patient is going to end up on dialysis, and quickly. Moreover, she has hemoptysis, so if you don't do something, she will die of massive hemoptysis. So do we treat with corticosteroids? Do we treat with corticosteroids and cyclophosphamide? Do we treat with corticosteroids and tacrolimus? Or do we treat with mycophenolate and rituximab? So why don't you think about the question, about the answer for a second, and the answer is going to be on the next slide. The correct answer in this patient is corticosteroids and cyclophosphamide. Why is that? Corticosteroids are not enough. Corticosteroids and tacrolimus also is not enough, and this is not an appropriate treatment for microscopic polyangiitis or for granulomatosis with polyangiitis. Rituximab with corticosteroids is appropriate, so you can go with corticosteroids and cyclophosphamide or corticosteroids and rituximab, but mycophenolate and rituximab doesn't make any sense. So this is why the correct answer is corticosteroids and cyclophosphamide. So this patient, I treated this patient with prednisone, 1 milligram per kilogram, tapered over 6 months. First, we gave methylprednisolone succinate or salumedrol, 500 milligrams IV daily for 3 days, and then the prednisone 1 milligram per kilogram tapered over 6 months. Cyclophosphamide, I went with oral. You can also do IV, 2 milligram per kilogram orally for 14 months. Remission was achieved after 2 months of immunosuppression, and since it was achieved after 2 months, we treat for a year after remission. The patient did not receive maintenance therapy. Doing maintenance therapy is never a bad idea. At least 1/3 would relapse, and you can do maintenance therapy with something like mycophenolate. You can do it with azathioprine, or you can do it with rituximab. And like I said, you can treat this patient initially with prednisone and rituximab. 3 years out, the patient remains in full remission, meaning her proteinuria is less than 300 milligram per gram creatinine. She doesn't have hematuria, and her creatinine improved, and it is 1.2 milligram per deciliter. So really good result. No hemoptysis. Let's talk about posse-immune or Anca-associated vasculitis. So we say vasculitis, one vasculitis, the plural is vasculitides, like glomerulonephritis, the plural is glomerulonephritis. But I'm not sure who want to say glomerulonephritis and vasculitides, so I'm just going to say vasculitis. Okay, posse-immune meaning when you do immunofluorescence microscopy, it's pretty much negative. You don't see much deposits, IgA or IgG or IgM, etc. So Anca-associated vasculitis, it's posse-immune, and you have here one of four possibilities. You can have granulomatosis with polyangiitis, formerly known as Wegener's granulomatosis. You can have microscopic polyangiitis, like we just saw. You can have anti-GBM disease, glomerular basement membrane disease, can be isolated to the kidney, or if you have lung manifestations like hemoptysis, is good pasture disease, or you can have just Anca-associated glomerulonephritis with crescents, Anca-associated crescentic GN without extrarenal disease. It can be confined to the kidneys. So remember this very important differential diagnosis. Very often, especially in an intensive care unit setting, you see a patient with pulmonary renal syndrome. Okay, so you have someone with hemoptysis, you have respiratory failure, you have acute kidney injury, you have proteinuria, hematuria. So what is the differential diagnosis? The top three, granulomatosis with polyangiitis, microscopic polyangiitis, and anti-GBM disease. Don't forget those. Cryoglobulinemia, henoxylon purpura, and SLE. Now, some of these diagnoses are not very common, but if you miss them, the patient will die. So this is why you need to know this stuff. Eosinophil granulomatosis with polyangiitis or Church-Strauss disease, this is not very common. Like I said, Church-Strauss usually does not involve the kidneys much, but you have to know about it, think about it if you have asthma. Rheumatoid vasculitis, not very common. Behçet's disease, I've never seen a case. Pulmonary edema with acute kidney injury, this is probably the most common. Okay, most patients are not going to have Behçet disease. They're not going to have microscopic polyangiitis. They're going to have run-of-the-mill pulmonary edema with acute kidney injury. They have pneumonia, they're in acute kidney injury, and they have pulmonary edema. Okay, but you have to think about other possibilities, because if you don't, like I said, the patient will die. Severe pneumonia, in particular Legionella, renal vein thrombosis with pulmonary emboli, and other uncommon diseases, paraquat, poisoning, vasculitis due to penicillamine, or hydralazine. So since we are on this topic, we said that we have several patterns, several clinical syndromes of glomerulonephritis. We said you can have acute glomerulonephritis, like in post-infectious GN, or you can have rapidly progressive glomerulonephritis. It's not as acute, but it's pretty fast. So here, think of anti-GBM disease when you have antibodies attacking the glomerular basement membrane, immune complex, ANCA-negative, RPGN, okay, like you would see sometimes in IgA nephropathy, lupus. Anca-associated disease, we just talked about that. Combination of Anca and anti-GBM disease, sometimes you have both, and this is something really left to the nephrologist. I'm not going to dwell on that. And sometimes it's idiopathic. You don't have anything. You don't have immune deposits, you don't have anti-GBM antibodies, and you don't have Anca, but yet you have crescentic GN and rapidly progressive glomerulonephritis, and you still have to treat it. This nice diagram is from my article. So when you have rapidly progressive glomerulonephritis, we are talking about crescentic GN. So you have these crescents. So you have one possibility, anti-GBM antibody. And if you have lung involvement, it's good pasture, or it can be just renal involvement, and we call it anti-GBM disease. How do we treat this? Well, very aggressively. We are going to do the prednisone and the cyclophosphamide, but we are going to do plasmapheresis. Posse-immune, Anca positive, can be PR3 positive or GPA, granulomatosis with polyangiitis, formerly known as Wegener's, or it can be MPO, anti-myeloperoxidase positive, or MPA, microscopic polyangiitis. Here we're going to treat with prednisone plus cyclophosphamide or rituximab Plasmapheresis, well, we used to do it. Now we have a big trial showing no benefit, so it's on a case-by-case basis. If you don't have pulmonary hemorrhage, probably you don't need to do it. Or this RPGN can be immune complex mediated. So on the immunofluorescence, you have immune deposits like lupus nephritis can give you RPGN, IgA vasculitis, like when you have henoch-Schönlein purpura, or post-infectious GN can be acute or can be rapidly progressive, a little bit subacute. So these are the three big categories of rapidly progressive glomerulonephritis. So what about the presentation? You have a steady decline in GFR. Sometimes it becomes acute. Sometimes it becomes very rapid. Proteinuria is there, but it's not massive. It's not nephrotic range. Severe hypertension is not common. You see that more in acute glomerulonephritis, like post-infectious GN, sometimes in lupus, especially if you have lupus vasculitis. If we don't treat the patient, the course is relentlessly progressive. You're either going to end with dialysis or even worse, death. And again, you have a cellular crescent. This is what's left of this glomerulus. And this whole thing is the crescent. And it's cellular. All these are cells in blue. So it's very obvious. Now here we have an example of active Anca-associated vasculitis. Again, this is what's left of the glomerulus. This whole thing is the crescent. And here you have necrosis, fibrinoid necrosis. This is why we call it necrotizing. Again, ANCA, you have p-ANCA or anti-myeloperoxidase. Actually, p-ANCA sometimes can be non-specific. You can see it with inflammatory bowel disease, but when it's anti-myeloperoxidase, p-ANCA, then it is significant. And this is, you can see, like I said, in microscopic polyangiitis, and P meaning peripheral. Okay, I'm sorry, P means perinuclear, so it's around the nucleus. Or it can be cytoplasmic ANCA, c-ANCA, or NTPR3. So it's directed towards serine, protease, proteinase 3, and this is associated with granulomatosis with polyangiitis, formerly known as Wegener's granulomatosis. With anti-GBM disease, glomerular basement membrane disease, this is what you see on the immunofluorescence. It's just the glomerular basement membrane that is stained. Okay, very nice picture here on the immunofluorescence. Again, another example of granulomatosis polyangiitis. This is what's left of the glomerulus, and this whole thing is crescent. See how cellular, how active this crescent is. This is when you really need your prednisone, your cyclophosphamide, or rituximab. Get your nephrologist, get your rheumatologist, and let them do what they do best. Last question here, number 13, 24-year-old woman with a 2-year history of systemic lupus erythematosus. She presents with microhematuria and proteinuria. The patient is on hydroxychloroquine. Exam shows blood pressure 114/58, heart rate 78, otherwise unremarkable. Urinalysis 2+ protein, 2 to 5 WBCs, and 10 to 15 RBCs per high power field. We have an occasional granular and, more importantly, occasional red blood cell casts. BUN is 14. Creatinine is normal, 0.7 milligram per deciliter. Urine protein creatinine ratio is 850 milligram per gram. C3 is normal, but C4 is depressed, is low. The patient has a positive anti-double-stranded DNA antibodies. The titer is high, 1 to 320. Based on that, we said when we have lupus, we have these findings: proteinuria, hematuria, anti-double-stranded DNA, very specific for lupus nephritis. We are going not to waste our time. We're going to do a biopsy to determine the class of lupus nephritis and subsequent treatment. So, without further delay, we did a diagnostic renal biopsy and showed class 4 lupus nephritis. This is diffuse proliferative. Which of the following is the most appropriate next management for this patient? Next step in management: do we give tacrolimus? Do we pulse her with corticosteroids followed by prednisone orally and mycophenolate? Do we give rituximab or do we give azathioprine? Now the answer is going to be on the next slide, so you can pause here if you like. The correct answer is B, pulse glucocorticoids followed by prednisone and mycophenolate. Using tacrolimus alone is not appropriate. You have to use steroids and something, preferably mycophenolate. Okay. Now you can add tacrolimus or cyclosporin later if it's not enough. Rituximab in and of itself is not appropriate. Azathioprine is good for maintenance. Okay. You can start with the prednisone, say, and cyclophosphamide, and then go to azathioprine. But just using azathioprine alone is wrong. Now, this is what you see in a biopsy of a patient with lupus nephritis. Now, here, actually, you have crescents, so you have a crescentic GN. Just looking at this, you cannot tell if it is lupus or if it is granulomatosis polyangiitis, microscopic polyangiitis. You cannot tell. Now, this is a biopsy of a patient with lupus nephritis. When you look at this glomerulus, it's clearly abnormal. Here in the very pink, these are hyaline thrombi. So inside the capillary loops, they should be empty, like here. You have thrombi, so this is very serious. Look how thickened the capillary loops are. Look at this mesangial expansion. Look, all that in blue is proliferative. So this is definitely very abnormal. You can see here these are red blood cells. Sometimes you can see the hematuria inside, like here, the tubules. Now this is what we call wire loop lesions, meaning this is what the capillary loop should look like, and this is what it looks like. So because of the immune complexes, because of all these very heavy deposits, they become like wire loops. Here, here, here also. Here, note the mesangial expansion, note the proliferation, okay? So this is also seen in lupus nephritis, it's characteristic. Now, on the immune fluorescence in lupus nephritis, they call it full house. So everything lights up. You have IgG lighting up, IgM lighting up, IgA lighting up, C1q lighting up. So everything, C3 lights up. So all of that is lighting up, and the deposits are mainly, as you can see, mesangial and also in the capillary. So very, very active process. This is lupus nephritis is the only thing where everything lights up. Now, the electron microscopy, this is why you have these wire loops. Look at these thick immune complex deposits, okay? And where are they? Well, they're everywhere. So this is let's orient ourselves. This is the endothelium, okay? This is the endothelial side. This is the epithelial side. And the deposits are everywhere. They're subepithelial, they're subendothelial, and intramembranous, okay? So this is why you have these wire loops, okay? All that, okay? So you have really heavy deposits, subendothelial, subepithelial, okay? And if the picture was bigger, we would have seen it in the mesangium as well. Now, I'm going to end here. Thank you for sticking around. The video could have been longer. I didn't cover other topics like membranoproliferative glomerulonephritis. This is very confusing. The whole classification has changed. I didn't cover, say, amyloidosis. I didn't cover the renally significant deposits of light chains, etc. Please read my article if you would like more information, and maybe we can cover that in a future video. Please like the video, subscribe to the channel, send me comments, and thank you for watching.